This data was collected from Chokoria, Bangladesh, which is located in southeastern part of Bangladesh near the southeastern coast of Bay of Bengal. Chokoria is one of the low-performing areas of the country with relatively high mortality and fertility and very low level of utilization of healthcare services. Healthcare delivery system in the study area comprised of public, private, and non-governmental organization commonly known as NGOs. So who is a village doctor? Village doctors are a group of informal healthcare providers practicing modern medicine, are dominant healthcare provider of rural Bangladesh. Given their role, it is important to examine their prescription pattern and inappropriate use of medication. The majority of the village doctors do not have formal professional training to provide modern healthcare services. Although the healthcare sector in Bangladesh has experienced policy formulation and healthcare reform in last 40 years, many rural people are still deprived from care provided by professionally trained healthcare providers. So what would they do? These poor, underserved people in rural Bangladesh, they go and seek care from these village doctors. Therefore, these informal healthcare providers have become sole provider for poor and underserved people in rural areas due to their easy access and consistent health services at the time of need. In another country like China, they also have village doctors who get remuneration from government for providing public health services in rural part of China. Moreover, village doctors in China are recognized in Chinese healthcare markets and are being integrated in rural China's surveillance system. No such mechanism exists for village doctors of Bangladesh, although they represent 80% of the healthcare providers in rural Bangladesh. In this secondary data analysis, we have found that a total of 2,587 prescriptions were written by village doctors during the survey period 2008 and 2010. Among prescriptions, what we have found that 10% of them were appropriate medication. At the same time, we have found that 8% of them were inappropriate medication. Combination of both appropriate and inappropriate medication were found in 63% of these prescriptions, and harmful medication were found in 19% of these prescriptions. Polypharmacy, which we defined as if more than 5 medications were prescribed in one prescription, in 5.33% of this prescription, representing 138 prescriptions. There were no time, interestingly, we found that where patients were not given a simple prescription. That means in each prescription there were at least one medication, and in all of these visits. All prescriptions included in the studies were written by 77 informal healthcare providers, which we are defining as village doctors. While we were exploring the determinants of prescribing inappropriate and harmful medication, we found that polypharmacy prescriptions were 6 times more likely to have harmful medication than prescriptions written with less than 5 medications. Lack of know-how about disease management and easily accessible medications might be the explanation of such prescribing behavior that we have found here in this study. These findings warrant effective and rigorous training and awareness program to impact the culture of overprescribing among village doctors. We felt that village doctors need to be incorporated within the healthcare system of Bangladesh with necessary training to avoid harmful practice and promote safe and quality care, especially for poor people of Bangladesh.